Hello everyone, my name is Sophie van Oosterwijck and today I'll present you my poster on how therapy can modulate the human nociceptive flexion reflex. And this is a summary of 2 systematic reviews and meta-analysis. Let me give you some background information first. The nociceptive flexion reflex is a spinal reflex allowing withdrawal from your limb from a painful stimulus. In laboratory settings, this reflex can be induced using painful electrical stimuli and assessed using electromyography of the flexor muscles. Previous research has already demonstrated that there is a linear correlation between the reflex outcomes and subjective pain perception. In human pain research, we use this reflex as an electrophysiological measure of spinal nociception. The NFR threshold arising due to single stimulation provides us more information on spinal nociceptive transmission, whereas temporal summation of the NFR threshold in response to repeated stimulation provides us with information on spinal facilitation. Previous research has already demonstrated that chronic pain patients have lower NFR thresholds and thus spinal hyperexcitability. Chronic pain patients might therefore benefit from interventions reducing spinal nociception. However, a systematic summary of the evidence for conservative and non-conservative treatment effects on spinal nociception measured using the nociceptive flexion reflex is lacking. It is essential to improve chronic pain care and therefore we perform 2 systematic reviews examining this topic. First, let's have a look at the methodology. Both reviews were carried out following the PRISMA guidelines. First, we performed the search strategy in 5 electronic databases, and which comprise of keywords relating to the nociceptive flexion reflex. The retrieved articles were screened against predefined eligibility criteria by 2 reviewers independently from each other. The methodological quality of the included articles was then appraised using the Cochrane Risk of Bias 2.0 tool by 2 reviewers. According to each NFR outcome measure, the quality of evidence was determined following the grade method. When sufficient data was available, mean difference or standardized mean difference and 95% confidence intervals were calculated. Let's have a look at the results. The review examining non-conservative treatment effects included 51 articles, whereas the review examining conservative treatment effects included 36 articles. The majority of included studies had a high risk of bias. This is attributable to the randomization progress or the description thereof. First, I'll describe the results of the conservative treatment interventions. We found that overall, conservative therapy is not superior to control therapy when it comes to modulating the NFR threshold. However, conservative therapy does significantly decrease NFR magnitude compared to control therapy. Sub-analyses were only possible for the control population, transcranial magnetic stimulation, and psychological therapy, which were all significant. Conservative therapy has also been found to significantly decrease NFR area compared to control therapy. Looking at the sub-analysis according to the population, both populations had significant results. However, when looking at the type of conservative intervention, only the sub-analysis including transcranial magnetic stimulation remained significant, whereas others did not. We also found that control therapy overall prolongs NFR latency compared to control therapy. However, when performing sub-analysis, the results were insignificant. Finally, we found that conservative therapy does not differ significantly from control therapy when it comes to modulation of the temporal summation of the NFR threshold. Let's move on to the non-conservative treatment effects. We found that non-conservative therapy significantly increases NFR threshold compared to control therapy. These significant results were maintained when performing sub-analysis according to population. When performing sub-analysis according to the type of non-conservative therapy, significant results were only found for pharmacotherapy acting on the musculoskeletal or nervous system and surgery. Overall, there were no differences between non-conservative therapy and control therapy when it comes to modulation of NFR amplitude or temporal summation of the NFR threshold. In conclusion, we found that conservative and non-conservative treatment modalities can exert immediate effects on spinal nociception, as was evidenced by alterations in certain NFR outcome measures. These results indicate that conservative and non-conservative treatment interventions might offer opportunities to prevent and treat chronic pain in chronic pain conditions which are characterized by enhanced spinal nociception. Given the immediate response of the nociceptive flexion reflex to interventions, it can serve as an appropriate tool to evaluate treatment strategies. Finally, the nociceptive flexion reflex is an important tool in pain research not only to evaluate treatment effects, but also to continue to unravel the underlying mechanisms and mediators of spinal nociception. Thank you for your interest in our research. If you have any thoughts, questions, or remarks you would like to discuss, please do not hesitate to get in touch.